Hi friends, so let's see day 9, some points regarding visual fields again, and I told you yesterday I'll tell you some points regarding optic chiasma. Okay, so the question which I asked in the morning is out of these four, there are two questions, which of this is not due to lesion in chiasma, that is the first question, and which is due to anterior chiasma involvement, that is anterior chiasma syndrome. Okay, so let us see some points regarding optic chiasma, then I will come to the answer of this question. Many of you have given the questions, the answer correctly, but let us see what can happen when there is a lesion in optic chiasma. Okay, so when you know that nasal fibers of optic nerve are crossing at optic chiasma, right? And if nasal are involved, there will be temporal field defect. Everyone knows this. This is known as biotemporal hemianopia. I told you yesterday, chiasma has heteronymous. Okay, heteronymous means not on the same side. So there is a heteronymous lesion on the temporal side, that is biotemporal hemianopia, that is seen in optic chiasma. That is very simple question. And two extra points over here is there is a nystagmus or a seesaw nystagmus and a bow tie optic atrophy that can also be seen in optic chiasma lesion grossly. Okay, but let us see some extra points now. We know optic chiasma is above pituitary gland. Okay, the crossing of optic nerve, optic chiasma, is above the pituitary gland. So if the question is asked, if there is a pituitary gland tumor, it will come from below. If it comes from below, then what will be the first visual field defect of pituitary tumor? If the tumor is coming from below, it will involve the inferior fibers of the chiasma first. And if inferior fibers are involved first, the defect should be superior. So the first defect of pituitary tumor will be like this. Both sides supratemporal defects will be there. Okay. Ultimately, of course, it will become biotemporal hemianopia, but the first defect will be like this. And there is another tumor which is coming from above, mostly seen in children. From Radke's pouch it comes, that is craniopharyngioma. So if the first defect in craniopharyngioma is asked, the answer will be superior fibers will be involved, so inferior defect of the visual field will be there. Both sides inferotemporal defect is the first defect of craniopharyngioma. Of course, ultimately it will become biotemporal. So these are some extra points over here. But let us go one step further. What happens in optic chiasma? Okay, if there is a lesion in the middle, right, that is the middle chiasma syndrome, then you get this biotemporal hemianopia or both sides supratemporal in pituitary, both sides inferotemporal in craniopharyngioma. But if there is an anterior junction syndrome, okay, what happens in my eyes, your eyes, the fibers, the nasal fibers, they make a loop and they cross. This loop is known as genu of Willebrand. It is normal. It is seen in your eyes and my eyes, and mostly the inferonasal fibers are the first to be crossed. So if there is a lesion in the anterior part of the chiasma, one side nasal and temporal both fibers are involved, so there can be central or total field defect of that eye, and the other eye will have supratemporal or temporal because inferonasal are the first to be involved. So this is known as a junctional scotoma, also known as anterior junction syndrome. Alright. This defect, this is also heteronymous. This can happen when both sides, this is very rare, when both sides temporal fibers of the chiasma are involved. Lateral chiasma lesion, like in distension of third ventricle or atheroma of the carotid or posterior communicating arteries on both sides, then it can have lateral chiasma lesions having binasal hemianopia. See, this is also heteronymous. Okay, and if there is a posterior junction, the answer in the option number, the only macular fibers are involved. In posterior junction, only the macular fibers are involved. So here, if you can see the option number C, this is a posterior junction syndrome that can also be seen in optic chiasma lesion. So this is optic chiasma. This is left side anterior junction syndrome. This is the first defect due to craniopharyngioma, both sides. This is heteronymous, both sides inferotemporal. And this is posterior junction syndrome. This is the answer of today's question, which is not a defect due to chiasma. This is left superior quadrant involvement, left homonymous, it is retrochiasmal. That is like a pie in the sky. Temporal, right temporal lobe lesion will have left homonymous superior quadrantenopia. That's the answer of today's question. And which is anterior involvement? Answer is A is the answer of today's question, of the second. Okay, let me tell you one more last point regarding your optic chiasma. So what happens in optic chiasma? The normal variation is that the pituitary gland is just above, just below the chiasma, which is in central 80% cases. The crossing is just above the pituitary gland. But if the crossing takes place before the pituitary gland, that is known as prefixed. So if the question is asked that if there is a prefixed optic chiasma, means the crossing is taking place before the pituitary gland tumor will affect what? It will affect obviously optic tract. And if the crossing is behind the pituitary gland, postfix means the crossing is taking place behind the pituitary gland. So in this case, the pituitary gland tumor will affect optic nerve. That is extra point regarding optic chiasma. Alright, so that is for today. Thank you for listening. Best of luck.